Okay, let's start.
So next is the hip dislocation. For the etiology, for pathophysiology, the common mechanism it usually occur in young patients with high energy trauma. For pathoanatomy that it usually involve including the bony anatomy and the soft tissue, including the labrums, capsule, and ligamentum teres. For the classification, it's we divide into posterior and anterior dislocation using the acetabulum as an anatomical reference. And for the posterior dislocation, it's occurred in almost 90% of the hip dislocation. The mechanism would be the axial loading on femur when the hip is flexed and adapted, as in the dashboard injury. And for the severity, it usually associated with the hip position. You could say that the increase in flexions and or adduction would favor simple dislocation, as in the picture. And the complication would be the osteonecrosis, posterior wall cerebral fracture, femoral head fracture, sciatic nerve injury, and ipsilateral knee injury.
So, what's the difference between the mechanism of the acetabular fracture and the hip dislocation, Buranee?
For the acetabular fracture would be when the hip is not in flex position, like decrease, not in increasing in flex position.
Okay, so keep in mind, if you are going to have the dashboard injury, like you drive the car and it's going to hit something, please flex the hip, deep flexion and adduction. Okay, so if you abduct the hip and you didn't flex enough, you have acetabular fracture. That is more worse prognosis, right? And difficult to treat. So flex and deep bending, flex the hip and adduction. And when you hit something, it will be simple. Understand? But if you abduct the hip, okay, you dashboard injury. So you have acetabular fracture. Okay, keep in mind when you going to hit something, you drive a car, right? And you cannot stop, flex the hip and dip and adduct. So when you have dashboards, so you do like simple dislocation. Actually, it's the same story. Yeah, acetabular fracture, posterior wall fracture, and hip dislocation. Okay, it's the same dashboard injury. Next.
So next is the anterior dislocation, in which the mechanism would be the femoral head impact or a chondral injury. And when the hip extends, it resulting in the superior dislocation. The patient will be in the hip extension and external rotation. And for the flexion, when the hip is flexed, it resulting in inferior dislocation, and patient will be in hip flexion, abduction, and external rotation.
So how can it happen? You know?
Like the anterior dislocation.
Yeah, which is the very common anterior dislocation.
Oh, like a common situation.
Riding a big bite.
Oh yeah, big bite.
Why big bite?
Because the posture when the driver riding.
Right, big bite, there is not adduct, right? They need to abduct. So when they hit something, you hit on the medial side of the knee joint. It's not from the front, right? On the medial side. So the hip will be abduct, external rotation. So every dislocation I saw in my life is from big bite. Okay. Next.
Next, I'll be talking about the presentation. That's slightly a bit minimal, but for the pain, the severe pain is the most common symptoms. And also with the separation of femur head from the acetabulum, the surrounding muscles and tendon could be damaged as well, and it's subsequently causing the could also causing the knee injury. So the knee pain might also present, and it could, as the tendon and muscle damage, it could also cause some degree of swelling. Another common presentation would be immobility. When the hip is immobilized and there's reducing in hip range of motion, then the patient could also come with the inability to walk.
Yeah.
As
So
a
show the
result
pictures.
of like.
So the patient have so much pain and deform, right? Show the clinical presentations.
So next, it's the clinical presentation.
Yeah.
So in posterior dislocation, when you're inspected.
So Natasha, this is anterior posterior dislocation, this patient. Natasha.
This patient is in posterior dislocation.
Why?
Because there is adduction and internal rotation.
Yes.
And the hip and leg is in like slight flexion.
Yes, right. Okay, this is the classic picture, right? You should remember, right? Whenever you saw the patient at the emergency room in this posture, thinking about the posterior hip dislocation. Okay, good.
So I'll talk a little bit about physical examinations first.
So that's it, enough. Okay. Flexion, adduction, internal rotation for the for the posterior. For the anterior is different. You can remember like in the shoulder, right? Shoulder anterior dislocation is abduction, external rotation, right? And the anterior, the posterior dislocation of the shoulder, also the same, right? Flexion, adduction, internal rotation. This is shoulder posterior dislocation. So symbol is the same, okay? But on the anterior dislocation of the shoulder is common. For the hip, the posterior is common, right? It's different. It's opposite. So now you mentioned about the nerve. Every time you dealing with the dislocation, thinking about what is the nerve at risk for the posterior. Pilun. Nerve at risk. Pilun.
Sciatic nerve.
Yeah, sciatic nerve. So sciatic nerve, there's two parts. There's a peroneal part and tibial part. Which part is common injury? Pirun.
Answer is perennial part.
Peroneal part. Because the patient will have foot drop. That is the peroneal part of the sciatic nerve, right? So how about the anterior dislocation, Bantavan? Where is Bantavan?
Hi.
Yeah, hi Bantavan.
Hi.
The anterior dislocations, what is the nerve at risk?
Anterior dislocation.
Which nerve is in the front? Which nerve is in the front? Arterial bypass.
Femoral nerve.
Femoral nerve is in the front, right?
Yeah.
It's in the front. So you need to check the femoral nerve if the patient has anterior dislocation. Okay. By checking.
By checking
the
popliteal.
No. Quadriceps. Yeah.
Quadriceps.
Right. The anterior femoral. The femoral nerve apply the quadriceps, so the patient have weakness of the quadriceps and numbness, right? Okay, very good. Next.
Next is the diagnostic procedure, which is the imaging.
Yeah,
I
actually
will
you don't
show
need to
the-
remember this. Yeah, it's simple, very simple. Don't
Yeah.
remember the words, remember the films. Go to the
ค่ะ
films.
so ตัวฟิล์มนะคะ
Yeah, go to the films.
So both posterior and anterior, there will be disruption of the Shenton line
Yes.
and configurance. Next,
So that is anterior posterior dislocations. Go back, go back, go back. That is the anterior posterior dislocations.
this one, me answer.
Yeah.
This is on the
Anterior or posterior?
the posterior dislocation
Yeah, posterior because
the femur head is smaller than the controller of
yeah, the smaller or bigger is difficult to interpret sometimes, right? You can say, but the important thing is the position.
it's the
right?
roof.
What is the position of the patient?
The position of the patient.
Of the hip.
The hip is flexion.
Yeah, flexion. Flexion is difficult to interpret because this is the AP films, right? But you can say there's an adduction, right? And this proximal migrate. For the anterior dislocation, the hip will go down. You go down, right, into the obturator foramen. It's like the anterior dislocation of the shoulder. The hip will go down medially, right? Same. So from this picture, we can see that the loss of Gothic arc, you loss of Shenton line, right? And also there's some adduction. And also you cannot see the lesser trochanter very well. That means this hip is internal rotate, right? So this is the anterior dislocation. Posterior dislocation. But sometimes you have some fracture of the acetabulum or the posterior wall. The deformity will be not classic if you have the wall fracture or acetabular fracture. Go to the second. Go to the next. Yes, to see this one. This is not classic, right? Because you look at the frames, you lost Shenton line. You look at the frames, the head is close to the top, right? But this one is not classic because the deformity is not too bad. Okay, if you look, it look like nearly normal. But if you look at the head, it's not concentric comparing to opposite side. You didn't see the superior joint line, you see? You didn't see the superior joint line. That means this joint is subluxation. Okay, because of the acetabular wall fracture. Okay, so this is the fracture dislocation. There's a wall fracture and this joint subluxation also. Okay, so whenever there is the fracture of the wall or acetabulum, the clinical side will be not so classic. Okay, understand? But you look at this, there's some adduction, right? Comparing opposite side, and you cannot see the lesser trochanter comparing to the opposite side, you see? That means this hip is internal rotate and adduction. Yeah. So that's the clue to tell you that this patient have posterior hip dislocation, and the picture is not classic, thinking about the acetabular wall fracture or acetabular fracture. Okay? Right? Buranee? Yes. And how about this one? Natasha?
So this
Natasha?
ค่ะอาจารย์
Natasha? Describe the deformity.
So this one, there's a loss in Shenton line as well.
Yes, of course.
And you can also see that there is a adduction as
AB
well.
or AD?
abduction.
Abduction.
Abduction, and you can see that the femoral head is rotated.
Yes.
Yeah, it's rotated
And
medial.
move.
and move downwards.
Downward and
And
medial or
also
lateral.
I think it's medial rotation.
Yeah, it's medial displacement.
Medial displacement.
Medial
Sorry.
displacement is going downward. Medial
Going down.
displacement, yes. So this same like shoulder dislocation anteriorly, right? And you can see the lesser trochanter quite obvious. That means the hip is external rotate. Okay, so abduction, external rotation, right? So this is a classic anterior dislocation. And the head is in the obturator foramen. You see this foramen? This is obturator type. Okay, so this is anterior dislocation, obturator type. It's not common, yeah, very rare, yeah. I saw at about less than 10 in my life, yeah. Okay, next.
So next is the treatment. So it could be non-operative, which it's you can do the emergent close reduction within 12 hours. Indication will be an acute dislocation. For the contraindication will be ipsilateral displaced or non-displaced femoral neck fracture.
Yeah.
You want me to show the video now?
You describe the pictures, these two pictures first. So first,
so
you need to do urgent emergency reduction, right? Why?
Because of the neurovascular involvement.
No, you yeah, that's another part. But the important thing is that you may have the avascular necrosis of the femoral head, right? If you delay reduction, okay? And you need to do the reduction at the emergency room or not? You say emergency reduction? Buranee?
From what I understand, it not necessary.
No, you must not do that at the emergency room. You must not. Why? Pantawan, why? You know why? Natapat, why? Because
possibly I think it's because first it's very pain inducing because of the tension of the muscles in the area as well.
yeah.
And also there could be complications from us reducing like iatrogenic as well.
Yeah,
that
right.
might require intervention, surgical intervention surgery.
Yes. You need the full sedation. You need full muscle relaxation. Okay, so that means you need to do that in the operating theater. Okay, do not do that at the emergency room. My fellows, Dr. Catherine from the Philippines.
Oh.
You saw her, right? She's a female orthopedic doctor. She did the hip reduction at the emergency room, she told me. And she got this prolapse. Herniated disc, because she tried to reduce the hip because the patient is big size and she need a lot of force to do that. Yeah. So should not do that for the in terms of yourself. You may damage your back. Yeah, you may have this herniations, and also it's not good for the patient. The patient have painful, and sometimes you can do iatrogenic injury, like you can create a fracture of the hip. Yeah, and also you cannot test the stability after the reduction. So keep in mind, do that in the operating theater. Yeah. So now show us the video. So these two techniques of the reduction.
So the first video will be showing the Alice technique.
So you ask your assistant to put the patient on the floor or put on the table, but most of the time we put the patient on the floor. because it's easier. Otherwise, you need to clamp on the table. Okay, so this is the patient position, and then you fix.
Be
So
going
after,
to the
yeah, stabilize the
the-
pelvis. Okay, so assistant stabilize the pelvis, and then bend the hip to 90 degrees. This way? No. No.
it's not
You
that
guys,
big,
come on.
right?
I need you.
So I can ask the Runti.
So for the hip reduction,
Okay.
you need these guys, okay? So first, after the sedation, you stabilize the pelvis, okay? Fix here at the ASIS. So you guys, you come here. Most of the time, you need to climb on the table. But
Not at this time, it's okay.
table is not
It's too
strong.
big. Too big.
So bend the knee, okay, to 90, okay, this way. Very good. And what we have to do is to pull up like this way, okay, to stabilize. Do it this way.
They are the first generation
Yes.
CICM, right? Ah, yeah.
This
You
way,
see, he's
okay?
very strong.
And then you track the hip outward. This way. Understand? So your assistant stabilize.
Stabilize the
You
pelvis.
push, you reduce this way. Okay, slowly, slowly, slowly. Okay.
Oh.
Okay.
Oh.
Okay.
Very strong.
So this
man.
is Alice technique. Okay.
Alice technique.
Another way is we call it.
Yeah, this is the Alice technique. Okay.
Next one it's another technique called left codes.
Left COVID. Not COVID-19. Okay. Left COVID.
Left
Take off your shoes.
LEF left. KO.
so
WITZ, right? It's like the Russian name something, I'm not sure.
Okay.
Okay.
This is left forward. You bend the knee like this. Okay.
Okay.
You use this to be falcon. You need to be the falcon. You understand?
Use the knee to be the
This is
falcon.
falcon, and then you bend. You put this down. Understand? Push this down. Hey, stronger.
Okay. So this the way.
Okay, this way. So this way is you use your knee to be the falcon. Okay, and push this down. Okay, it's like leverage technique.
Leverage technique.
Okay, slowly this way.
Yeah.
And this knee you can help by like this. Okay.
But make sure that the knee is
Ah,
okay.
yes.
Yeah. If the patient have knee problem, you cannot do this, right? Because you use the knee as a falcon.
Like this.
Yeah.
You okay? So this is another way. Same like that Alice technique. Same like Alice.
Same way.
But you use the knee to be the leverage technique.
Okay. So this two ways. So these are our preferred techniques. Actually, there's more than I think 20-30 techniques of the reduction. Okay. You can do in prone position like Stimson, same like the shoulder reduction. Okay. Okay, very good. Next. So after the reduction,
Foot.
So after the reduction, the theme, right?
mm-hmm.
Oh,
Buranee,
sorry, Hajan. I didn't bring the post reduction theme.
okay, no. I mean the what will you do next after you reduce the hip back? So when you reduce the hip, you can feel like it's reduced, right?
Weight bearing
It's pop
followed by
in. So what is the advice for the patients? So after the reduction, you move the patient out of the theater, right? And before going back to the ward, what would you do? Huh? X-ray, right?
X-ray or CT.
How can you order the X-ray after the reductions?
Um,
One hip or both hips?
the AP and the lateral costable
No, lateral costable is too much. So you order both hips AP. Why both hips?
To compare with the other side.
Yes, you need to compare the opposite side to see that the joint is concentric or not. You need to measure the joint space, both sides is equal or not. Why? Because sometimes there's some fragment from the acetabulum entrapped into the joint. So this act like the foreign body in the joint. Okay, you need to check it out. So always looking both hips after the reduction to see that is symmetrical or not. Okay, looking at the joint space. So is it not the same? The joint space is not equal. The patient needs surgery. Okay, to check it out. This piece of bone, right? So actually, you have another video. Can you search the hip dislocation and my name? So I showed you the real patients. Go to YouTube. YouTube, yes. And hip dislocation and BANCHA, yes. I think the first one, yes, this one, yeah.
This one.
So that's the real patients. See, this is in the theater. You see the knee? Yeah, this is the Lepkowitz techniques, okay? See? Yeah, it's in, right? And then you see how to check the stability, see? You need to bend the hip to 90 degrees and push. Yeah, push it down, okay? Push it down this way, okay? It is stable, that means this hip is stable. But if the patient have the posterior wall fracture, big piece of bone, the hip is not stable. When you push down, it dislocates again, okay? So after the reduction, don't forget to test the stability. Okay? So it's in simple dislocation, it's always stable. Because the hip joint, the socket is very deep, right? It's like this, yeah. So it's very deep. So when you reduce it back, it's always stable.